continuation of yesterday's topic, which is laboratory tests related to hematology. Okay, so yesterday we talked about what ESR. Can you guys hear me? Okay. Medyo late, Charis, pero sige lang, push. Alright, Adrian, why were you raising your hand before we continue? Do you have anything else?
My apologies. A while ago we weren't live yet, but it's okay now.
Okay, okay. Alright.
Thank you.
Okay, thank you so much for that wonderful introduction. Oh, for that wonderful confirmation of our live stream. All right, now hemoglobin analysis is the second test that we're going to talk about. Now this doesn't include hemoglobin electrophoresis. Okay, I'm going to discuss. It's going to be discussed in a separate topic. Okay, I like to discuss things that are related to each other so you guys can understand. Hemoglobin analysis is basically just the manual methodologies of analyzing the hemoglobin molecules in the human body. Right. So hemoglobin analysis. Let's go with our slides. The two names for hemoglobin analysis could be what? We could use, hang on a sec. Somebody's messaging me. Trey, annoying. All right. So there's two methods under the another name for it is cyanmeth hemoglobin method, or we call it the hemoglobin cyanide method, or HICN method. Now I'm going to refer to it as HICN method from now on, so you guys are familiar with the terminologies. Now, the reagents that we use for this one is basically, hang on a sec. Sorry. The reagents that we use is potassium ferricyanide. There's a mix-up with the slides. Potassium ferricyanide, potassium cyanide, dihydrogen phosphate, non-ionic detergent solution, and distilled water. All right, so those are the reagents that you need for your HICN method. Okay, that's the reagent name. What's the chemicals included? Okay. Next is the chemical name is Drabkin solution. All right, and sorry, we can use an accelerating reagent to increase the reaction time between between the blood and the reagent that we use. Okay, so Drabkin's reagent uses dihydrogen potassium phosphate, and bicarb can be used instead of sodium bicarbonate. Okay, sorry, sodium bicarbonate can be used. Sorry, it can increase the reaction time to 3 minutes from the original 10 minutes. Okay, so don't forget to use don't forget the Drabkin's reagent. All right, Drabkin's reagent is the name of the reagent, and we can use an accelerating reagent, which is sodium bicarbonate instead of dihydrogen phosphate. All right, so be mindful of this slide because it came up in one of the question banks for some of my students in the past. Okay, now what is the function of an anionic detergent in the to the Drabkin's reagent? Well, it prevents the turbidity caused by erythrocyte proteins. All right, so it prevents it from interference, basically. Why? Because the HICN method is a spectrophotometric method. All right, so please be mindful of the importance of every reagent that we have in the tests. Okay, now how is it calculated? How is hemoglobin calculated using the HICN method? Well, we use absorbance, of course. As I mentioned before, it is a spectrophotometric analysis, and it measures the absorbance of the formula is basically as such: absorbance of the unknown plus divided by absorbance of the standard multiplied by the concentration of hemoglobin in milligrams per deciliter. All right. Now, this is again one of the questions in the question bank. So please be mindful, especially when it comes to calculations. You're going to see why I keep an emphasis on writing the concentrate the formula for every type of analyte that you're going to encounter today. All right? So it's not just for hemoglobin. There's also corrective calculations for retics, corrected reticulocyte count, absolute counts. So be mindful of those things. All right? Now, dilutions can be used in um, we can do several types of dilutions rather for HICN method, and we have one is to 251 and one is to 201. Why is it important? Because when you get and how do we do this? Basically absorbance of the unknown times absorbance of the standard multiplied by the concentration of the standard times the dilution factor. Now, why is this important? Because there are some samples that require corrections. Some samples require dilution. Now, Drabkin's reagent cannot be used as is all the time. There are some disease states that causes the sample to become turbid. And one way for you guys to measure it is through dilution. And 1 is to 251 and 201 is basically the point at which you need to dilute the sample. Now, is it standard for all? According to the books that I've read, it has always been 251, and very rarely I see computations used in 201. It's usually 251, but I added 201. Sorry, I added 201 in the equation, so you guys have options. All right, but most of the time the standard dilution is 251. All right, now what is the main advantage of the HICN method? Well, it can measure hemoglobin, many hemoglobin variants, okay? But the only thing that it cannot do is a specific hemoglobin variant. So it can measure hemoglobin, oxyhemoglobin, carboxyhemoglobin, and hemoglobin. But it cannot measure sulfhemoglobin. All right? So these are the hemoglobin variants that I'm talking about: oxyhemoglobin, carboxyhemoglobin, hemoglobin, and it cannot measure sulfhemoglobin. All right? Cool? Understood? All right? Okay, so if the question asks you which of the following hemoglobin variants is not detected using HICN, or which of the following hemoglobin variants could be considered as a limitation, then that's the time you're going to answer sulfhemoglobin. All right? So I'm just helping you guys out. It may or may come out of the exam that I'm preparing, but you know me, I ask it differently. All right? So I want you guys to comprehend what you're answering. I want you guys to practice reading comprehension skills as well as critical thinking. Now, what are the sources of errors in HICN method? There's actually a lot of sources. I actually enumerated 4 based on what is written in the books. Errors inherent to sample, errors inherent to the method, errors inherent to the instrument, and errors inherent to the operator. So these are the 4: the sample, the method, the instrument, and the operator. What are the possible sources of error inherent to the sample? Hemoconcentration, turbidity of the plasma, and lipemia due to lipemia in icterus, right? So how do we combat these things? You need to do dilution. What is the dilution? Again, guys, it was asked several minutes ago. Just confirming if you are... All right. The most common one. What about the other one? There's two ways. dilutions that you can do. 201. All right. What about what about the formula for the diluted version of hemoglobin analysis, of hemoglobin computation? Ayan, si Joanna Baltar, ang bilis. Bonggang-bongga. All right. So, what about the computation before we move on? How do we compute for the diluted hemoglobin values? Hello? Hala, yan na. Nakalimutan na. Ay, ayan, oh. Oh, kulang na lang.
Taray ng ano? Taray nung
Ang
may ano?
bilis. Ang
Absorbance of the
bilis.
unknown.
Ang bilis, no? Diluted version, te. Medyo kulang. Alright? So, sige, tutulungan ko na. Absorbance of the standard, absorbance of the unknown, divided by absorbance of the time of the MA. Nabilib na sana ako kay Joanna Baltar.
Hindi ko maalala.
Nabilib na sana ako. Nakita ko absorbance of the MA. Oh.
Hindi ko ulit.
Kahapon ka pa.
Anong meron kay Baltar?
Nalala ko sagot mong neck.
My neck, my back, and my... Ay, ako, Baltar. Kahapon ka pa nga. Tama nga naman. Alright, so babalikan natin, okay? Don't worry, girl. I got your back. Sabi nga ni Adrian in using his urban accent. Girl, I got your back. Ganon. Alright, so somebody helped you out. Absorbance of the unknown multiplied by the standard times concentration of the standard times dilution factor. Very good. Very good. Noreen Fortunato, please give her a round of applause. Thank you so much. Diba? Give the girl a round of applause. She took time on typing that. Let's confirm. Actually, I kind of forgot how to compute that one. All right. So dilutions can be used. So here, absorbance of the unknown, absorbance of the standard, concentration of the standard, and dilution factor. All right, divided by 1,000. Right. Don't forget the 1,000. Okay. Now, let's go back to possible sources of error inherent to the HICN method. Again, as I mentioned before, sulfhemoglobin is the only thing that you need to remember. Alright? Sulfhemoglobin. It cannot be detected by the method. Alright? It cannot be detected by that method. Try as you may, but you cannot do it. Alright? Now, what are the possible sources of error inherent to the instrument? Well, again, this has something to do with the precision of the sample, of the results. Pipetting errors are included. Okay? Maybe your pipettes aren't calibrated and they are not pipetting the exact amount indicated on the volume, on the volume or the graduation. Maybe your cuvettes are cracked, or there is a damage in the light bulb of the instrument itself. So there's a lot of factors coming in, or expired standards. So there's a lot of things that can be inherent to the instrument, but these are the most common things, because these two things affect the precision of the results. Okay, one is associated with the errors of calibration. Other one is associated with technical error or technical abnormalities in the instruments being used. Okay. Now, safety precaution when performing HICN method. All right. So we're delving into laboratory management and safety. Okay. It's always important for you guys to remember this one also, because if you are a person who have prospects to work in the United Kingdom or the United States, safety precaution is one of the most important things that you need to remember when you're doing tests associated with hemoglobin or hemicyanide methodology. Cyanide is, of course, poisonous, and it's a chemical that often creates fumes. All right, and you need to discard your reagents in running water. All right. So cyanide is poisonous, and it can create toxic fumes when a person is exposed to it chronically. All right, chronically. What do I mean by chronically? Like for example, I don't know. Every start of the duty, Adrian and Joanna would often go to the lab and they would make chica. All right, yeah, they would make chica 30 minutes on a daily basis for 2 years. Every time they would make chica for 30 minutes, they would leave the tap of the. They would oftentimes leave the cap of the reagent box open. Usually, these things come in a box right now. A lot of the automated analyzers right now still use hemoglobin analysis. So, for example, as I mentioned before, Adrian and Joanna would make chica 30 minutes a day for 2 years, and then at some point they suffered from, and then at some point they sort of felt a chronically ill from cyanide poisoning. So you need to discard the reagents, of course, in a dedicated sink, a chemical sink with running water. All right. That is based on ISO. On ISO, this particular slide was taken from what was taken from ISO, as well as the several package inserts that I have received from Abbott as well as from Beckman Coulter. All right. So I've worked with several machines that does hemoglobin analysis, automated hemoglobin analysis, of course. And usually, this is how we discard the sample: a dedicated chemical sink with running water. All right. Cyanide is poisonous, guys. Please don't please don't come into the laboratory without proper PPE, of course, as well. All right, especially if you're working in the histopathology laboratory. Um, when I was working in the Philippines, whenever I would be partnered with an intern, or I would be given an intern for my section, I would always make sure that my interns are protected properly, because my license um is also dependent on how I supervise the interns. For example, the intern suffered from chemical burns. I could be I could have an incident report which could result to me being either suspended or revoked based on based on the performance that the intern does. So it's a double-edged sword. On one hand, the intern can learn. On the other, if I neglect my duties and help and did not inform the intern about working in the laboratory safely, and a certain event or a certain incident occurred, associated related to my neglect, that could result to me being revoked, my license being revoked. So I've always put emphasis on I could I've always put emphasis on the safety of the interns I'm partnered with when I was working in the Philippines, because I'm scared. Because I'm scared for my license. It took me like how many years to get the license, and then some recklessness in the laboratory can result to me losing my license just because I neglected to inform the student about it. So when you're working in the lab and you're partnered with an intern, you will notice you will notice that some of the people oftentimes disregard safety. All right. Now let's move on to sickle cell screening. This is another test that you guys will be encountering in the laboratory if you're working abroad. In the Philippines, not so much, because consanguinity in the Philippines is very rare. Okay? What do I mean by consanguinity? Anybody knows what's consanguinity? Anybody? What's consanguinity first before we begin? It's a genetics question. Consanguinity. Anybody? From the word sanguine. From the root word sanguine. Parehas na line. Napapasa po sa parehas na line ng genetics. Alright, good.
Anak po.
Alright. Okay, Adrian, what were you trying to say?
Sir, parang minanap ng ganyan po.
Mm-hmm. Consanguinity is that's not what I'm looking for, but Joanna almost had the answer. Consanguinity means parents are related. Okay, the mother and father of the parents are of the kid is related. Ganon, ganern. Ika nga ni Joanna, ganern. All right. Okay, so it's not very common in the Philippines to see sickle cell anemia. Um, the first time I saw sickle cell anemia in the Philippines, it was I think I when I was about to resign. I was practicing for 2 years, and there was only one instance that I encountered sickle cell anemia. And it wasn't even from a Filipino; it was from a foreign visitor. So it's very rare in the Philippines, but it is one of the questions that are oftentimes asked in the exams. So let's talk about the methods to determine sickle cells, to screen for sickle cells rather. So usually in other countries they would call it a sickling tests. All right. But for purpose of sounding official, we always call it as sickle test or sickle cell tests. All right. Now again, this is going to be discussed further when we talk about hemoglobin electrophoresis. I have a dedicated lecture for hemoglobinopathies. So please be patient. We're just going to go at the basics first. Okay. Now, you need we have what you call saline citrate tests or saline citrate with paraffin, sodium sorry, sodium metabisulfate method, and the solubility testing. All of these tests follow the same format. They are all chemical methodologies, and their main purpose is to induce low concentration of oxygen, promoting the polymerization of the hemoglobin molecules, and thus causing the cells to become drepanocytes. All right. Okay, so what is the principle of saline citrate paraffin test? Well, the cell suspension of blood with saline citrate is allowed to stand under a layer or a layer of paraffin oil. Okay, and then this mimics the condition of a hypoxic environment. Remember my story yesterday about my coworker who has a kid that had that has sickle cell disease and thalassemia trait. Um, just allowing her to play around and run around the house is going to exert a lot of effort, and is going to induce a hypoxic condition to the kid. And basically, if these people if patients who are suffering from sickle cell disease suffer from hypoxia, the cell starts to sickle, and that is what you call a sickle cell crisis. Okay, so in terms of in vitro testing, the suspension of blood and saline is allowed to stand under a layer of paraffin oil. The paraffin oil basically creates a vacuum that prevents the entry and exit of oxygen, and this creates a hypoxic environment, resulting to the sickling of the cells. Now, one thing that we can do here is we can examine it under the microscope. It's a little tedious, but it does the job well. It's actually one of the best ways to determine the sickling of cells. And I've only done this once as a test experiment when we receive a reagent lot of the kit for sickling test, and we didn't like it. We actually relied we actually performed better with um with the solubility test. But it was a fun way to test for sickle cells. Another thing that you can encounter in the laboratory is the sodium metabisulfate method. Now, this method mixes blood with sodium metabisulfate, and the blood drop is sealed and covered with and it's sealed and covered with a to in a, with and a cover slip is sealed to accelerate the sickling process. Metabisulfate and the sealing action of the cover slips causes a decline in oxygen and thus inducing a sickling phenomenon in the RBCs, and then it is examined under the microscope. This one is much more direct. You use the use a blood drop mixed with sodium metabisulfate, and then and then a cover slip is added to induce sickling phenomenon, or again a hypoxic environment. Decline in oxygen tension, it's just a fancy way of saying hypoxia. All right. Now, next, what is the positive result for saline citrate and sodium metabisulfate? Well, you examine it under the microscope. Both of these methods are microscopy related. Okay, both of these methods are microscopy related, and it could be done. It could be done at room temperature for 5 to 10 minutes. All right. The positive result is of course sickle cells. All right. 5 to 10 minutes after incubation. Is it tedious? Yes, it is. But it is better. There's lesser room for error in this one. If the examiner is if the microscopist is experienced in doing the test. But the chemicals for solubility. What is chemicals for the solubility? What chemicals can we use? So we're moving on to the solubility testing. Okay, we can use several chemicals. All right, one for solubility testing. First one is of course sodium dithionite, which is a reducing agent. Saponin is the lysing agent, and then phosphate buffer and the ionized water is used as well. Um, no, please take into consideration the first two because it might be asked in the exam. A dithionite. I remember one of my students said, "Sir, what is sodium dithionite used for?" It was asked in a question when I was taking the board exam. Sodium dithionite. All of the following are actions. Or which of the following is the use is sodium dithionite used for? Okay, so so that was one of the questions that was returned back by my one of my students who took the exam, Philippine boards. Okay, so I remember that's why I would often if I make these types of slideshows, I would often ask what is the importance. I can't just give you guys the list of reagents. I need you guys to know what's the importance of every reagent that happens here. Every reagent that I listed. So, of course, phosphate basically functions as a buffer from the name itself, and the ionized water is, of course, useful for deionizing the solution. Obviously, the name from the name itself, it is very straightforward. But sodium dithionite and saponin is something that you need to remember. All right. Now, the samples that may be used for sickle cell tests, we can use EDTA, heparin, and citrated samples. The samples need to be stored at room temperature. At 4 degrees Celsius, not at room temperature, for 21 days. Right? Anything longer than that would be subject for discard. That's also the reason why we often throw our samples or discard our samples in hematology for more than for a month. They are stored in our laboratory refrigerators for a month, and then we discard them. 21 days is of course standard the standard standard storage day, the standard number of days for this specific test. But for our hematology laboratory, it's 1 month. So please be reminded about the storage time, okay, and the temperature, of course, right? What is the positive result for solubility testing? Well, since you're talking about solubility testing, if the cells are sickle cells, if the patient has sickle cells, or you've induced sickling to the patient's cells, you are going to observe turbidity. All right, you're going to observe turbidity, and there are limitations, of course, for testing. It cannot differentiate sickle cell trait or sickle cell disease. What do you mean by sickle cell trait and sickle cell disease? It cannot distinguish hemoglobin variants, of course, caused by sickling, like HBS. So let's talk about these things for a while. What do I mean by sickle cell trait? Well, of course, when you are born, normally a person would either have a what? Sickle cell trait. Your hemoglobin phenotypes would either be AA slash BB. Alright? So what do I mean by this? AA and BB. These are alpha chains, these are beta chains. Most commonly, patients who have sickle cell trait will have one alpha chain and one sickle or mutated alpha chain group, and then other ones would be beta. Okay? So that's a sickle cell trait. Sickle cell disease patients, they would have hemoglobin S on both alleles. All right? So that's basically the my brief discussion on on what you call this, trait and disease. All right? So trait, you're just carrying a gene. You may suffer from sickle cell crisis. It could be a mild form of sickle cell crisis, but not all your cells will develop. Not all your cells will have sickle cell anemia. That will have sickling tendencies. All right, so that's one of the limitations of this test. Okay, another one is sickle cell disease. The whole cell, or majority of the cells in your body produces a hemoglobin S. All right. So, what do you mean by hemoglobin variants of HBS? There are several variants, of course. Don't forget, this is just a review. Hemoglobin SC, hemoglobin CC, and then hemoglobin Bart's hemoglobin. All right. So, what's Bart's hemoglobin, by the way? It's hemoglobin HbH. Everything is basically beta chains. All right. So please don't forget those hemoglobin variants. This again cannot be detected by your sickle cell screening test. Okay? Now, sir, would it test positive? Yeah, it would test positive for all of this. But you need to do hemoglobin analysis studies. Now, what we do here in our laboratory, for your information, is that we do what you call hemoglobin studies. We either run it through an electrophoresis machine if the physician wants the actual peaks and throws of the hemoglobin variants, or the hemoglobin molecules, different hemoglobin molecules, or we can do high performance liquid chromatography, which is again another form. If they just want to have a quantitative analysis of the patient's hemoglobin variants. So what does it do? What happens there? You're going to see reports like these. Both of them will have reports like these: hemoglobin A, hemoglobin A2, hemoglobin A1C, and then hemoglobin S peaks are here. This is usually for normal patients. For patients with hemoglobin S, we'll have hemoglobin A. Usually for, sorry. Ay, kamali ako. Usually for patients with hemoglobin sickle cell anemia, you would see a report similar to this. Hemoglobin A, hemoglobin A1C, hemoglobin A2, something like that, and then everything else. There's a peak at the top, That's hemoglobin S. All right. So, what is the importance of knowing this as medical technologists? Sometimes, sometimes you're going to be asked, is the patient positive for sickle cell? Because because some patients will be subjected to the same hemoglobin, same hemoglobin studies, but their disease is not sickle cell anemia. It could either be thalassemia. Okay, so thalassemia would oftentimes have the same thing, but they have what you call S windows. So what do you mean by S windows? Hemoglobin S windows. These are windows wherein there's a peak and throw of the activity. What do I mean by activity? When you run the sample in the analyzer, or say for example a high performance liquid chromatography hemoglobin analyzer, it will have values that is specific for the S window. And when this is seen either at a small amount or or a high amount, there is a quantitative value that would indicate that okay, this patient is suffering from sickle cell disease. Okay, so there's a value for that one. It's part of advanced hematology top. It's part of the advanced hematology discussions, and usually you will not be asked these types of questions in the exam. It's for pathology. It's for pathologists. So don't worry about these types of questions. What you need to remember as medical technologists is to know the limitations of the tests that you're doing. Okay, so our job is to help out the physicians find the best possible outcome in terms of diagnosing the patients. Okay? Not diagnose the patients. Our job is to assist only in the diagnostic in the diagnostic in the diagnostic portion of medicine. All right? So bawal magpaka-Jollibee ha, Joanna. Joanna, wag magpapaka-Jollibee. All right? All right? Our job is only to assist the diagnostic process of medicine. All right? Okay ba 'yon? Aljoy Aquino, do not help out in the diagnosis. I do not help the physicians reach the what do you call this? Don't help the physicians. You're going to help the physicians in diagnosis, but you're not going to help them decide what's the diagnosis. All right? Okay? If that makes sense, I don't know. If it makes sense, but um, most of our job, most of the things that we're going to do is mainly in the technical sense, and their job is to diagnose the patients and get the best outcome for their patients. Okay, now let's move on to um, false negative results for sickling tests. So there are three causes of false negative results. Of course, patients with anemia, right? You need to have there needs to be a certain amount of blood cells in your suspension when you're doing sickle cell testing or sickling tests. Okay, infants would usually have HbF, and therefore they would have would have high amounts of still in their body, or trace amounts of HbF, and therefore they shouldn't be tested first in their first few weeks for sickling tests. All right, and patients with sickle cell who've had blood transfusion or recently received a blood transfusion. So these are the things that you need to remember. Anemic patients. So how do I do sickling tests for patients with anemia, for anemic patients? Okay? You need to centrifuge the patient sample. You can correct all of among the three examples that I've listed. This one is the only one that you can correct in the laboratory. You need to get a certain amount of cells from the patient, make a cell suspension from that patient using using the centrifuged portion of the anemic patient sample. And that way we can have more cells to react and more cells to produce to induce a hypoxic environment, because the problem, especially if you're using turbidity methodology, if you're using the turbidity methodologies, is that there's not enough cells that would be lysed, and therefore you wouldn't see the turbidity that is accentuated by that is accentuated as a positive result of the test. So you need to have a certain amount of red blood cells to react. Now, false positives this time is going to include the following causes. Mainly, this is related to the patient's condition. It's either the patient is suffering from erythrocytosis, increased RBCs, all right, hemoglobinemia, all right. So if the patient is suffering from a hemolytic crisis, all right, hemoglobinemia, not hemoglobinuria, all right, extreme leukocytosis, such as those cases of leukomoid reactions, all right, and the hyperlipidemia, all right. What is erythrocytosis? What kind of case would you expect someone to have erythrocytosis? Huh? It's a very common test. It's a very common discussion that I will discuss to you next time we meet, when we're discussing specific pathologies related to hematologic disorder, related to the blood. What disorder is associated with erythrocytosis? Starts with these initials. Anybody?
Polycythemia vera po.
Ayan, gigil na gigil. Pero hindi ko kilala kung sino yung nagsalita. Who's that? Who that? Sabi nga ni Adrian, using his urban accent. Who that? Who said that? Ganon. So, who said polycythemia vera? Nabigla ako. Si Noreen po. Okay, thank you, Joanna, for helping us out. So, Noreen is very active today. I love it, Noreen. I want you to have the same energy when you're answering questions. So, thank you so much. So, polycythemia vera is actually going to be the cause of increased erythrocytes in the body. All right? Hemoglobinemia, leukocytosis, and hyperlipidemia. Thank you so much, Noreen. All right? Para hindi na mahirapan si tayo yun. Ay, taray, meron malang shared dito, hoy. Pag nag-exam ka, ikaw lang kung anong result, kung anong deserve mo, yun yung sa'yo lang, ha? Hindi kayo shared ni baka mamaya niyan, magbigay ng 100 item exam si Sir Marco. 25 ang nakuha ni Joanna, 25 din ang nakuha ni Noreen. Pinag-add din yung dalawa, ha? Kayong dalawa talaga, ha? Nagkakaloko-loka kayo, ha? hindi pwede yon. Alright? Okay. Nag-fusion na naman kayo, ha? Kayo talaga. Alright? So, Adrian, yun. Kasi kanina, I know, I think you're going to ask me using your urban accent na naman. Who said that? Gaganon ka na naman. So, ako, sinagot na ni Joanna for us. Alright? Next. We're going to go with the so this is basically the answer for correcting anemic. What I mentioned earlier. False negative sickling test can be corrected if the patient is anemic. So all you need to do is use packed red cell when retesting the sample. All right? The patient's hemoglobin is less than 6. Sorry. If it's less than 6, or it's less than 7 rather, which means it's a panic result. All right? You need to do analysis on centrifugated samples. All right? Now, we're going to go with peripheral blood smear. So, next time we meet, I'll show you videos of a friend of mine who does peripheral blood smears flawlessly. I would say her blood smear, the blood smear that she does is divine. Or divine. It's magnificent. And every other word that you can say to any other word that you could say, it's beyond perfect. And everything that she does when she makes blood smears for me is a work of art. And I'll show you why and how she does it. Okay? Next time we meet. All right? Now, this is the study of the structures and forms of the cells and tissues and organs. Of course, this is the study of morphology. All right? The study of structures and forms of cells, tissues, and organs. Morphology. All right? So we study the morphology of cells when we're doing a peripheral blood smear or a PBS. All right? Or you can say peripheral blood film. If you're working in if you're working in an institution that says film, that's fine as well. All they need is a peripheral blood smear. All right, so the equipment used for peripheral blood smears, of course, a clean glass slide and your spreader slide. All right, so we have you could use a spreader, either it's a cover slip or it's another clean slide. Okay, so these are important things that you need to remember because there's several techniques out there. I've tried using cover slips to smear my blood smears, but I could never really create that tongue shape and the coronal diffusion at the end. So usually your smear is going to look like this. Pardon the drawing. It's going to be tongue shaped. Okay, it's going to be tongue shaped, and there needs to be a space in between this one. All right, needs to be a space here on this side. Okay, so pardon the drawing, but you need to have a tongue shape, and you need to have what you call a corona at the edge of the tongue. They call it the corona. Why is it the corona? Because this is what you call the top of the smear, the very top of the smear, the part of the smear that the microscopist would look at. Okay, so this is the corona. All right, now do I need to remember this, sir? Yes. Why, sir? Well, if previous examinees have already proven, our examiners in the Philippines are very meticulous when they're asking questions, and they would ask the length and the width of the smears, the ideal smear, all right, and the thickness as well. So the length and the width is at 75 to 25 millimeters. The thickness is 1 millimeter. All right. Really, sir? How would I know if it's 1 millimeter? But that's basically the theoretical dimensions of an ideal smear. All right. It came from Rodak. Kasalanan ni Rodak to, okay? So kasalanan ni Rodak kung bakit kailangan ninyong alalahanin. And again, if you don't know this, might as well not come to the exam room because this is going to be an expected a question that you're going to expect time and time again as you keep on taking your exams for your hematology reviews. All right? Now, what is the preferred blood sample for PBS? Ano bang ginagamit natin? So, nag-practice na ba kayong gumawa ng smear? Kasi naalala ko nagkukwento sa akin si sir ninyo na gumagawa daw kayo ng smear tapos may isang student pinagpipilitan niya na basophil daw yung isang cell kasi kasi dark blue daw. So medyo masakit sa ulo 'yon. All right? So what is the the anticoagulated tube that you're going to use? Anybody in the chat? Adrian, mamaya ka na. Baka mamaya baka sabihin meron akong favoritism. I'll ask your other classmates first. What is the answer to this particular slide? You guys know? Toot toot toot. What about Eleanor Tomas? What type of anticoagulated tube are you going to use for creating your PBS or your peripheral blood smear? Anybody? Anybody here? All right, Aljoy.
EDTA po.
EDTA. Okay. Very good.
Sir,
Wonderful. EDTA.
capillary blood.
Um, the correct answer that I'm looking for is EDTA. EDTA samples. All right. Why? Capillary blood can be subject to morphological issues. All right. Now, capillary blood, if you're using capillary blood, it could be wonderful for malarial smears. All right. But ideally, your blood sample should be EDTA. Okay? Purple or lavender tab. Okay? Venous blood sample. Why is capillary blood um not preferred? Because you're using finger sticks. If you're using finger sticks, you might cause hemoconcentration when you're squeezing the patient's hand or finger when you want to create a smear. So it might cause morphological issues, especially when you're forcing the cells to go out of the capillaries. Another thing is that it might cause falsely increased concentration of RBCs in your smear. All right? So it would be best if you used it if you smeared directly from your tubes. If you're looking for malaria or parasites, that's good. But for the purpose of morphological studies, the ideal sample is anticoagulated blood from an EDTA sample. Okay? Cool beans. All right, we're going to move on with our next question. Somebody unmuted. Is somebody going to contest what I said? I heard somebody
Sige,
breathing.
sir, may dadagdag lang sana ako.
Oh, sige, sir.
Hindi, hindi, kasi I think in public hospitals, common kasi yung capillary sample,
Mm-mm-mm.
diretso sa slide.
Mm-mm.
So I think that's what this student was trying to say.
Yeah. There's no question about that, sir, because it's the lack of the yeah.
Normally there's nothing wrong with it, but in my experience, hindi ko gusto yung distribution ng cells sa PP. Pag galing
Pag capillary.
capillary.
Yeah,
Yes.
talaga, sir.
Distribution ng cells.
Yeah. Cause first thing the one thing is I remember when a student asked me before when I was still working in the Philippines, sir, bakit sila ma'am gumagawa by finger stick needle, but ikaw ayaw mo sa finger stick. One thing that I noticed is it's dirty. For practical reasons, it's dirty. And for microscopy purposes, the distribution of the cells is again, as you've said, it's not equal. It's not really good. The quality of the smear is not also going to be good because the cells would probably dry faster if it's not anticoagulated. Okay, so I wish you another thing is you cannot control the flow of the blood if you're using capillary blood collection samples. From my experience before, we still do it back then. Especially I worked in a private hospital. We would do it there. Yeah, we do it even bedside. The pathologist even would request us to do it bedside, and I don't like it. It's messy, and if you're gonna work especially now during the pandemic, and you're doing that, you're going to violate a lot of safety protocols in many hospitals abroad. Because in hospitals abroad, the technologist usually just collects the blood sample and gets out of the room. That's the best way. That's the best way for me to. If you're going to violate not just safety laws but as well as infection control policies. In hospitals here where I'm working right now, they don't like it when the technologists does blood work in front of the patients.
Yeah.
Yeah. So has something to do with infection control as well as there's technical issues, and for me personally it's messy. So yun.
Yes,
Anyway,
it is. Super messy siya.
yeah, napaka-messy talaga siya.
Bibigyan ka pa ng patience na gumawa ng smear, tapos papalit ka
Oo.
pa.
Imaginein mo mag-isa lang ako noon, Sir Marco. Nandun ako sa may fifth floor. Tapos pawis na pawis ako. Jabar na jabar pa ako dahil summer. At the height of ano yon, at the height of dengue season. My God.
Alam ko yan, familiar ako sa dengue season na yan.
At the height of dengue season, every pediatric patient who's been confirmed to be diagnosed with dengue NS1 needs to be needs to be tested also. We needs to have an accompanying slide that has been collected bedside. Imagine, oh my God.
Yes.
That's actually one of the reasons why I don't like to work in the Philippines as a medical technologist. Magtuturo na lang siguro ako pag pinadala nila ulit ako diyan. Nakakapagod, nakakajabar talaga, sir. Ang ganda-ganda pa naman ng outfit ko. May
Nakikita
ganda
ng mga
kas.
students
Oo.
na
Pero
sobrang
enjoy.
glamorous ng trabaho.
Oo. Pero enjoy siya kasi may makachika-chika ka ng mga pasyente. But at the same time, if you're a person who's not really into speaking with patients all the time, it's not going to be very, as you've said, glamorous. Kasi nakasuot ka ng lab gown, or sa amin kasi blazer kami na hanggang dito lang. Ang init-init noon, my God. Tapos yung amoy ko pa pagkatapos nun dahil nandun ako sa ward na walang aircon. Si kuya kumakain ng piatos, tapos nandun sa may amoy bulok talaga. Oh my God. I can't. I really can't. Ang arte ko talaga. Charat! Charat. Ang arte ko talaga. But yon, binary blood, you can use it. But in terms of theory, in terms of theoretical, theory is different from practice, okay? Theoretically, what is going to be asked in the board exam and what you should answer when you're taking your exams is EDTA, anticoagulated blood, okay? So we're not preventing you to do it, all right? But
I'd like to point out lang din kasi na I think some of our students right now, working na sila. Not
oo.
as medtechs, but as
Oh,
preparators.
wow. Wow.
So I think kaya na-bring up yung example na yun eh.
So, theory is different from practice, okay?
Exactly.
Isa yan sa mga isa yan sa mga dahilan.
Theory is
Oo. Isa yan sa dahilan kung bakit may mga staff ako, may mga colleagues ako sa work na nabubwisit sa mga intern. Kasi sasabihin sa akin, alam mo, nabubwisit ako diyan kay intern blank natin. Sabi, bakit? Binabasahan ako ng libro. Ito siya pagtrabahuhin ko niyan. Gagana na. Binabasahan ako na sa libro. Sir, kasi sabi ni Rodak, ganto-ganto po. Di ba dapat hindi ano? Remember, the main purpose that you're coming here in the seminar is to review for your board exams. Okay? So, try to make a fine line kasi you're going to be hated in the laboratory if you keep saying those kinds of things. There's a certain culture when you enter the laboratory. O, di ba ibang klaseng seminar talaga to, no? May real life situation, pa. May mga real life situation stories pa ako. You are going to be hated in the laboratory if you keep saying those kinds of things. There's a certain culture as well as a hierarchy in the laboratory. You can't just go in there even if you're the smartest student there. People are going to hate you if you keep on saying, if you keep on correcting the policies and procedures that are being done in the laboratory. I know it's not ideal, but it is the culture of laboratory professionals. And if you're going to enter into practice, do what they're doing first, and then flex your knowledge. That's my advice to you guys. Okay?
That's true.
Saka ka mag-flex kapag ka naka 1 year ka nang ginagawa yung trabaho nila, or head ka na ng section, because there's really a hierarchy there. Okay? And right now you might be employed as technicians, I'm not sure, lab technicians, or lab technologists. I don't know how, but MTL 5527, somebody might be violating the law here, but
No, I think Sir Flebo lang sila.
Flebo. Grabe ka naman sa flebo lang. Over ka naman. Sir Marco, over ka naman sa flebo lang. Um,
I mean,
but,
level ng work nila. So, usually,
okay, okay.
taga-collect ng specimens.
Alright, okay.
So,
At least we clear, at least we
nag,
cleared it.
hindi sila nag-analyze, hindi sila nagbabasa.
Okay. Okay, okay, good. But at least you guys are still exposed in doing laboratory work, and phlebotomy is part of your training pa rin naman. All right? Unless na lang matuloy yung
Sorry sumingit kasi usually kasi there's a dissonance between sa theoretical and application.
Mm-mm.
So, minsan nasa-shock yung estudyante.
So, pag review classes, libro ka. Pero pag nandun ka sa laboratory, wag mong pahiyain yung sarili mo, wag ka magpakita ng abilidad doon, ha. Ako mismo ang kukurot sa iyo. Kung ako ang staff mo, akong kukurot sa iyo. Ano ako ng mga estudyante, may forceps ako doon. Tabi, hahatakin ko ng forceps. Tabi diyan, mali ang hawak mo ng pipette mo. Pag nasa microbiology ako, gaganunin ko. But they still love me. I'm a big B in the lab, but they still love me naman. Alright, so next question. Ideal distance of a blood drop from the edge of the slide is 1 centimeter. Alright? So sir, tatanong pa rin ba to sa board exam? Yes! Yes, tinatanong siya sa board exam. Guys, tinatanong talaga siya sa board exam. Okay? It wasn't asked in my board exam personally, but my classmate who took the exam a year, I think months after I took the exam, they said that Manuel tinanong yung distance nung slide from the edge of the smear. From the yung start ng smear from the edge of the slide. Tinanong yun. So, wag mo kakalimutang idagdag yun sa mga lecture mo pag nagturo ka na ulit. So, yun, ganun. Alright, so what angle should the spreader be when you're making a smear? Again, are they going to ask this question? Yes, they're going to ask you this question. I'll also help you guys out later because there is a situation when you're going to when you're going to increase the angle and when you're going to decrease the angle of the smear. Alright? It's 35 to 45 degrees. Alright? Okay? The ideal shape of the blood film is tongue shape. Okay? If the ideal shape is tongue shape. Wait, there's supposed to be a slide here. Next. Ideal shape of the blood film. Okay? So if the patient is anemic, what would be the best way to make the smear? Increase the smear and make a thicker blood smear. Increase the angle and make a thicker blood drop. Alright? Think opposite for polycythemia. Always think opposite for polycythemia. You're going to be asked a question in the board exam. Patient has this and this type of blood counts. You would know based on the knowledge that you know that the patient's RBC count is low, that the patient would be anemic, and therefore select the best way to create a blood smear for this patient. Usually they would ask that kind of question. What do? Do I make a thin smear or do I make a thin blood drop or a thick blood drop? Okay? So these are the cases where you need to create or increase the angle when smearing because the blood drop is thicker. All right? So for polycythemic patients, it's the opposite. Thinner. Why? You want to have an equalized distribution of the blood cells. If you will create a blood smear for polycythemic patients, the same way as you would make one for someone who is anemic, you're going to see the cells overlap, and you might confuse it as rouleau formation. All right? So that's one of the things that you need to take into consideration when you're making a smear. All right? Theoretically pa rin siya. All right? Okay, so it's tongue shape with the feathery edge. The feathery edge is what we call the corona. Okay? Ideal length of the blood smear is 3 centimeters. I think I already wrote it there in the previous slide. I just had a mild stroke probably when I was typing the questions. Okay. Now, possible ways to dry a smear. You could either do air drying or you could do hot air drying using a using a humid in humid conditions. All right, hot air drying or low wattage incandescent light bulbs. I was lucky enough to have a slide dryer when I was working in my previous work. They have a slide dryer there. It uses an incandescent light bulb, low wattage. Don't need to burn the cells. Okay, it basically what the smear dryer looks like is that it's it's a box where there's light bulbs there, and you just need to place the slides there. The glass on top of the slide is is conductive with is a conductive glass where the heat that comes out there would cause the blood films to dry faster. Hot air drying, I think in some institutions, if especially if the patient sample is rushed, needs to be rushed. We have pathologists sometimes there in the Philippines that would often be too demanding and needs you to create a smear as fast as possible. So you might use a convection oven for this one, but I don't usually advise this one. Why? Because it might cause the cells to it might cause the smears to bubble up. Okay, especially kung sobrang init nung convection oven nyo. So I always suggest the usage of air drying. Okay, air drying talaga siya lalo na sa Philippines. Okay? Pang social lang yung slide dryer na low wattage incandescent light bulbs na yan. All right? Now, if a blood smear is placed close to a heat source during drying, what would occur? This is something that I said earlier. There would be artifacts seen in the microscope. So you can see red blood cells there, and then there might be some sort of artifacts that you're going to see, because it would cause the hemoglobin in the cells to precipitate, and this usually would be considered as a basophilic stippling. In some books, it would look like basophilic stipplings, but it's really not. Okay, so we want to avoid artifactual findings in your peripheral blood smears. All right. Now, what can be observed microscopically in an ideal smear? Well, you're going to see the cells overlap with each other throughout the slide. An even distribution of WBCs throughout the slide. Reject the smear if it's concentrated on one end of the smear only. This is the thing that I was talking about earlier. The distribution of the cells is important, especially when it comes to WBCs. For instance, I'll make a drawing here for you guys. And this is your blood smear. Okay? I'm going to change it to yellow. On this side, you can see a lot of WBCs here. All right? And a small amount of RBCs. And on this side, you're seeing only RBCs and maybe one WBC. And when you look at the patient result in the book, in the computer, you see that okay, the hemoglobin is normal, the WBC is normal, but when you look at the slide, there's something wrong. There's something off with it. Okay, so it might be that the sample was taken from a capillary blood sample, or the sample was hemoconcentrated, and that the cells were pushed out of the vein, the capillaries, and resulted to an uneven distribution of the cells. Or the smear itself when the technician or the technologist was making the smear, he did not use proper. He wasn't able to. He put 2 blood drops. I've seen this several times, especially in my interns. With my interns, they would make 2 blood drops because I think it's not that enough. It's not enough yet. So it would look like an ideal smear, but if you use 2 blood drops, and they're in varying sizes, obviously this one would have more would have little amount of cells, small amount of cells, and this one would have more cells in there. And when you smear it, it would it would have a disparity on different locations of this cellular disparity or cellular distribution disparities on different locations of the smear. So reject it immediately. Okay? I've seen some of my interns do this several times because they are quite they're used to making a smear. All right? And they can make a smear with a feathery edge, but they just think that the blood is not enough, so they add an extra drop on the end. So avoid doing that one. Okay? Kasi when you paano ko ba explain to sa inyo? When you make a smear, minsan nabibitin siya, hindi siya nag-aabot dun sa edge. Paano ba? Wait, tingnan ko muna yung itsura ko sa camera, baka hindi niyo nakikita. Nakita niyo ako sa camera, no? So, for example, ito si slide, kunyari malaki siya, ganyan. Alright? So, sometimes kapag ka nag-smear ka, gaganyan mo yung smear mo, 'di ba? Ayan yung spreader slide mo. May makikita mo yung blood, 'di ba? Parang gaganon siya. Mag-spread siya automatically by capillary action, right? And sometimes hindi siya aabot dun sa dulo. So yung mga estudyante ko, ang ginagawa, dinadagdagan ng blood dun sa kabilang side. Okay? Which is a big no-no, ha. Huwag niyong dadagdagan dun sa side. Kasi
Sir.
Totoo. Nakita ko yun dun sa mga Okay, mga ko yun, mga UST intern ko yung gumawa no. Nakita ko lang, sabi ko bright talaga. Sabi ko bright talaga tong mga student ko sa mga UST intern ko na to. Pa sila, parang ginawa nilang team effort yung paggawa ng smear. Kasi yung isa nandun may hawak na pipette, yung isa sa kabilang gilid. Yung isa may hawak na pipette dun sa kabilang gilid. Drapan mo. Kasi hindi umaabot, nabibitin kasi siya. So nakita ko yun, okay. Nakita ko, anong ginagawa ninyo? Gumagawa ng smear, sir. Ba't dalawa kayo? Ba't parang group effort ang paggawa ng smear? Sabi ko, kasi sir, hindi umabot dun sa dulo. Sabi ko, huwag nyo gagawin. Kasi napapansin ko that day, sabi ko, ba't parang ganun? Ba't parang kakaiba yung smear? Ba't parang hindi pantay yung And then makikita mo din naman kasi may demarcation line sa gitna yung yung smear. Oo, may demarcation line sa gitna yung smear. Sabi ko, ganun pala. So, ganun. Naalala ko lang yung mga intern ko sa MCU. At saka sa UST. Nakita ko parang group effort pa talaga. Nakita ko yung isa may hawak na pipette. Ginaganon dun, dinadagdag dun sa gilid. Pinapatakan dun sa gilid. Okay? So, yan. So, if a slide is greasy, what would happen to the blood smear? Obviously, you're going to see holes in the smear. All right? You're going to see holes or streaky lines. If there's dust, you're going to see a patchy looking smear. And if there's inconsistent pressure, you're not going to see the feathery edge or the absence of the feathery edge. Okay? With inconsistent pressure. Okay? Streaky film when it's greasy. Paano nagiging greasy? Hindi ka nag-gloves. Hinawakan mo yung slide. Actually, minsan babakat pa yung fingerprint mo. Okay? So, don't hold the slide like this, okay? When you're making a smear. Hold the slide. Remote control talaga yung ginamit ko. Kasi siya lang yung rectangular dun sa ko eh. Okay? So, don't hold the slide like this. Hold it on the side. Alright? Hold it on the slide. And don't use dusty slides, of course. If you're going to get dusty slides, you can clean it with a cloth or a tissue. All right? And inconsistent pressure. So yun nga, inconsistent ang pressure mo, mas may force ka dito sa side na to. Kaya Mas maganda talaga yung version na ginagawa ng friend ko na isang slide pa ganun lang siya. Hindi pa ganito. Kasi usually merong inconsistency sa pressure. Alright? Constant lang ang ano. Usually ang advice ko sa mga students na nag-start pa lang gumawa ng smear, hindi pa talaga sila gumagawa ng smear ever in their life. Just be confident. I don't know why. When I say that one, be confident lang. And when I say that piece of advice, they get that piece of advice from me. They would make wonderful smears. And yon, wala lang, share ko lang. All right, next. What causes artifacts in the film? Well, of course, water. Most of the time, you're going to make your smears near a body of water, which is of course the sink. Why? Because you're staining it there also. So you're going to expect to avoid. You need to avoid water. All right. Another thing is expired tubes. If you're using expired tubes, you might see EDTA crystals in your blood films. Okay. And unfiltered, unidentified, underfilled tubes. Sorry, underfilled tubes. Again, you're going to see crystals there as well. Okay. Next, what are the types of stains used in smearing? Well, we have several. We have polychrome stains. Sorry, polychromatophilic tuloy. Polychrome stains, monochrome stains, and supravital stains. So there's those are three types. Can anybody give me an example of a supravital stain that I mentioned earlier? Yesterday. Sorry. Can anybody give me an example? Anybody in the chat or you can type it in the chat, guys. All right?
New methylene blue.
Oh, new methylene blue. Sino 'yun? Oh, it's Adrian. Sorry, it was Adrian. I medyo na-shock lang ako kasi you're not using your urban accent today. All right, BCB. What are we looking for with BCB? Joanna. Joanna.
Ano pa kasi yun?
Naku. Madi-disappoint na naman nito si Sir Marco pag hindi mo nasagot yan, ha? Do not disappoint Sir Marco. Hoy. Nasa ka na, Joanna? BCB. What are we looking for when we stain your bloods? What are we looking for? Yesterday, sinabi ko yon. Maturation series.
Reticulocyte po.
Yeah? Another term for reticulocyte. Anybody aside? Thank you, Joanna. What's another name for your reticulocytes or retics? Nakalimutan na nila yung maturation series. Kahapon lang natin pinag-usapan, guys. Kayo talaga, ha? Huwag kayong manonood kaagad ng Tulfo kasi. Tsaka nanonood ng mga debates muna. Saka na tayo manood ng mga presidential debates na yun. Polychromatophilic ano? Madaming polychromatophilic. Hoy! Polychromato. Madidisappoint na naman si Sir Marco dito talaga. Kayo talaga. Polychromatophilic ano? Normocyte, normoblast. Polychromatophilic normocyte or normoblast? Ana Jamema, nag-unmute ka. Ana Jamema, ano?
Normocyte po.
Alright, wonderful. Thank you so much.
Nako, buti na lang. Magagalit na sana ako.
Magagalit na naman. Magwawala na naman. Mag-ano na naman to. Magra-rat sa akin to si Sir Marco sa chat.
Natandaan yung klase yung blast. Lagi na sa dulo yun. Lagi na sa simula yun.
Actually, sasabihin ko pa lang sana. Buti yung sinabi mo na. Pag polychromatophilic normoblast, mas nauuna siya. Okay? Laging nasa dulo. Pagka polychromatophilic normocyte, yun yung malapit nang maging mature. Okay? Tandaan nyo lang yun. Huwag nyo kakalimutan, guys. Parang awa nyo na. Para hindi para maglalaro kami ng sir ninyo ng Genshin na hindi na i-stress, okay? All right. Give an example of polychrome stain. monochrome stain, and a supravital stain. So we already know this for the ticks, new methylene blue or BCB. Okay, a monochrome stain is Pearl's Prussian blue. I'm going to ask later what's the usefulness of Pearl's Prussian blue, but I want you to look at Giemsa and Wright stain. All right, Giemsa and Wright stain. Giemsa stain is basically used for more on parasitic microfilm, usually for parasitic blood film identification. Here in my workplace, we're using Leishman and Giemsa stains for parasites to better visualize malarial ring forms, trophozoites, and everything like that. And on one case, we've seen somebody with a filarial worm. Right stain, we use it mainly for RBC morphology and WBC morphology studies. Okay, so polychrome stains and right stain. Now, in the books, both of them are of equal importance, and the only difference between the two will be discussed later. Pearl's Prussian blue. What do we use it for? Anybody? Adrian.
Pappenheimer bodies po.
Okay, thank you. What are Pappenheimer bodies made out of? Patay tayo dyan, nakalimutan. Pappenheimer bodies. Alright, we're going to come back to that one. Thank you guys so much for answering the questions. Now, let's move on with the difference between right stain and Giemsa. Now, right stain and Giemsa, basically, they're almost the same. But the difference is that Giemsa is used mainly for the detection of the cell wall or identifying parasites. The right stain is usually used for identifying cell types. Okay? Chromosomal aberrations. I forgot to mention chromosomal aberrations for Giemsa. What kind of chromosomal aberration are we talking about? Figure of 8. A figure of 8 in your RBCs. What do you call that RBC anomaly? We're going to talk about it next time we see each other. But I just want you guys to have a little bit of a review. Figure of 8. What do you call a figure of 8? In the RBC morphology. In an RBC morphology. Come on. What do you call the figure of 8 abnormality? It's made up of filaments or chromosomal filaments. And it's usually seen in patients with a chromosomal aberration. Figure of 8 in an RBC. Sometimes it looks like this. Anybody? Common yan na question din, di ba, Sir Marco? Yung si figure of 8 in an RBC morphological anomaly with a figure of 8. Ana Jamema.
Sickle cell po.
Oy, figure of 8. Drepanocyte yon, yung ano, oy.
Ano sabi niya? Sickle cell?
Oo, naku, madidisappoint talaga si Sir Marco ngayon.
Kabot rings.
Sorry, sir.
Ayun na, narinig.
Kabot rings po.
Kabot rings. Okay. Ana Jamema, ha. Tandaan mo kung paano mo dinisappoint si Sir Marco today, ha. Ana, lagot ka.
Si Alipio
Sabot
ang
ring
absent. Na-hurt ata kahapon.
Na-hurt din siya. Kaya malaki na si Alipio.
Absent siya ngayon, oo. Na-hurt daw siya.
Malaki na 'yon. Hindi ako maniwalang na-hurt 'yun. Napakalaking lalaki nun. Diyos ko. Hindi bagay sa kanyang ma-hurt. Kabot ring daw. Kulang ng kabots dapat. Apostrophe S, ha? Baka mamaya bigyan kayo ni Sir Marco ng exam na ano, ha? Na mamali kayo ng spelling. Apostrophe S, okay? Pero I would accept kabot ring. All right? Thank you so much. All right. Now, what's the difference between Giemsa and Wright stains in terms of composition? So this one in terms of usage. This one in terms of composition. Well, in terms of composition, both of them are almost the same. They have both eosin and methylene blue, but Giemsa stain has an added component. It uses Azure B. Okay? Azure B. to strengthen the bluishness, or we call it a bluing agent. If you're not, if you're familiar with your histopathologic techniques, you would often see the term. You would often come to the term. You would often come and see sometimes the term bluing agent. So Azure B is your bluing agent. Then methylene blue and eosin. All right. Next. This is a blood film stain that may be used as a rapid stain without the need of a fixative. This one is the one that I'm always familiar with. A rapid stain, if you see the word rapid stain, that would be your keyword, without the need of a fixative. By the way, before we answer this question, what is the best fixative? Histopathology review for blood film and bone marrow samples or bone marrow aspirates. What is the best? Anybody? This could be asked in your histopathology technique questions or histopathologic techniques. The best. Ano may sinusulat ko sa ano? Anybody? What is the best fixative for blood and bone marrow aspirates? Pag may nakita akong nagsabi ng formalin, ako, madidisappoint din ako. What is the best fixative for blood and bone marrow? This is a question that is going to be asked either in hematology or in histopathology. Anybody? Anybody in the chat? Let's ask somebody from the group. Let's try somewhere at the very bottom. Let's try Lindel Arisgado. Lindel Arisgado. What's your answer? Is Lindel here?
Yes, sir.
Alright, so what is your answer? What's the best fixative for blood and bone marrow aspirates?
Methanol po.
Alright, good. Wonderful. Yay, hindi ako na-disappoint. Okay, kasi hindi niyo sinabing formalin. Yay! Alright, thank you so much. I think somebody answered in the chat, but may question mark kasi. So, if you're not sure, I will not accept your answer. Pag may question mark. Alright, so the best, the rapid stain that is used without the need for a fixative is Leishman stain. All you need to do is just flood the sample with Leishman stain and then wait for 12 minutes and then wash it out with water slowly, of course. All right? Wash it out with water slowly, and then you already have your smear. That's the reason why I love the Leishman stain. It's very easy to use. Right, the most common fixative for blood smears is methanol, as I've said earlier. But an alternative fixative could be 95% ethanol, of course. All right. Now, since we're talking about methanol, what is the problem? Or, for example, you ingested methanol. What would be your... This is not hematology related, but it could be a question that is going to be asked in clinical chemistry, specifically in the topic of toxicology. What would be the main problem in the patient who has ingested methanol? Anybody? Ethanol, iniinom natin. Walang problema. Pero pag napasobra, may liver problems tayo. Methanol, anong pwedeng mangyari sa'yo? Gin bulag. Very good. Very good. Somebody said gin bulag. Toxic for cause ng blindness. Sure po ako. Ayan. Permanent blindness. Very good. Sure po ako. Pwede ko naman narinig ang boses mo. Next time, Jenny naman magsasalita ka na, Jenny, ha? Okay ba yan? Okay. Hindi siya nag-okay. Hindi yata siya okay. She is not having it. Alright.
Natuto na sila last semester sa Gene Bulag.
Oo. Natuto na sila sa gene bulag. So, gene bulag ka talaga kapag ka methanol. Alright, very good guys. Now, eosin binds to what structures of the cell? It binds to alkaline structures, specifically hemoglobin. Methylene blue and azure blue binds to acidic structures like the nucleus and cytoplasmic RNA and basophilic granules. Okay, basically they are basophilic granules. Or basophilic, this is a basophilic stain. Eosin is an acidic stain. Okay? So it stains red to pink. Okay? Methylene blue stains black to ano. So ano yung naging problema natin, Sir Marco? Yung nagkwento ka sa akin, may student na ano yung kinuwento sabi may kinuwento sa akin si Sir Marco, pinagpipilitan ni student na may basophils daw siyang nakita. Let
Yes.
Yeah.
Huwag na lang natin ibanggit ang pangalan kasi
Oo, hindi ko ibabanggit yung pangalan. Ano ka ba? Hindi ko na nga maalala kung sino yun eh. Pero let me just remind you that when you read your blood smears, the least amount of cells that you're going to see, especially even in my practice, I've been working. I hope I don't sound like I'm an arrogant person, Sir Marco, but I think I've been working in the laboratory clinically for more than you, right?
Yes, sir.
Yeah. So from a practicing medtech's point of view, all right? Guys, the only time I've seen basophils reach greater than 5, I've been working for more than 10 years. Okay? I've been working for more than 10 years in the clinical lab. And the only time I've seen basophils greater than 5, actually 8 nga yung nabilang ng pathologist namin, is when the patient was actually suffering from lead poisoning. And that's very rare. We've had patients who are suffering from lead poisoning, and the value of basophils would still reach 2 to 3. It's not that much. All right? And doon sa kinuwento sa akin ni Sir Marco, may nagbilang daw ng, how much was that, Sir Marco?
10 yata yun.
10 pataas. Yeah. So, guys, when you've counted more than 10 basophils, question yourself. Ask yourself this question. Did I stain the sample correctly? That's the first thing that you're going to say. That's the first thing that you're going to question. That's the first thing that you need to do first. Because when you pass this sample, or when you send this sample for a consult in a pathology review with your pathologist, pagtatawanan kayo ng pathologist ninyo. And I don't want you to be in that situation. I don't want you to be in that kind of situation. Pagtatawanan kayo ng pathologist ninyo. Okay? So, guys, when you make a smear and you've counted a lot of basophilic structures, not just basophils, okay? And you see a lot of basophilic structures there, ask yourself the question, did I do the procedure properly? Because if it was, I would have probably stained it. I think I've stained it with methylene blue for a long time. I dipped it more than the required amount of time. Okay? So, tandaan nyo yun. Guys, 10 taon na ako nagpa-practice, guys. Ngayon ko lang narinig na nagsabi sa akin si Sir Marco na 10 pataas ata yung ano. Hindi ko maalala kung ilan yung sinabi niya sa akin. Basta 10. Medyo na-shock ako. Kasi sabi ko, isang beses lang ako sa 10 taon kong nagtatrabaho, 5 yung basophils niya. And that,
sir, this is not just one student, ha?
oh my goodness. Alright?
Hindi ko na lang babanggitin yung mga pangalan nila.
Oh my
This
goodness.
is not just one student.
Okay, so guys, be careful when you're identifying the cells, ha? Okay? Be careful. Alam mo naman kami ni Sir Marco, we are at constant correspondence because I always ask what the questions you guys have trouble with. Okay? Kaya nga meron kami, we've developed this what you call this evil laugh. Yung evil laugh namin kapag pinapahirapan namin kayo. Actually pag gumagawa ko ng question, napakahirap ba tong question na to or kailangan hirapan ko pa? Minsan nag-ano pa ako sa kanya, nagko-consult pa ako sa kanya kasi baka mamaya napakadali kay Adrian yan. Sabihin ni Adrian in his urban accent, he would say, "Sir, why are you making easy exams? This is nothing. This is a piece of cake." Gagano niya si ano. I can imagine Adrian's face when he sees easy questions. So I would oftentimes consult with Sir Marco about the exams that I'm making kasi baka mamaya nadadalian kayo eh, 'di ba? Gusto ko yung ma-challenge kayo.
Mas mahirap.
Oo. Pero mamaya naman yan, may ibang situations na, ay, ang dali lang pala nung sagot. Pinahirapan ko lang yung sarili ko. May mga questions din ganon. So you never know your footing when I'm making the exam. You never know where you stand. Or in Tagalog, hindi mo alam kung saan ako lulugar. Okay? Alright. So, that's it for peripheral blood smear. We're going to move on with reticulocytes. This is going to be my last topic before we go to break. Okay? So reticulocyte counts are one of the things that you need to take into consideration when you're reviewing for the board exams. It's a mixture of automated, but sometimes it can be done manually, especially when you see in the machines a result that has something like this. What's that, sir? Greater than. Usually you would see that when the sample is when the count is so high that the machine's linearity, when I say linearity, this is the range at which the machine has the capacity to count the samples. All right? You're going to hear the word linearity several times when you discuss clinical chemistry, but there is linearity also in hematology. Okay, so when you see a lot of greater than samples, that's the time that you're going to do either a dilution of the sample or a corrected version of corrected count of the reticulocyte counts. So it can be done automated using an automated analyzer, but most of the time when I was working in the Philippines, it's oftentimes done manually. And that's the reason why we have a counter at hand. Okay. Disclaimer: a lot of questions in my exam that I'm going to create for you guys is computational, and I don't think it's a leakage naman siguro, sir, kung sasabihin ko nakasama doon yung mga retics. Pero it's your job as students. Hindi naman siya leakage, no?
Sa board exam yan. Sige lang.
So hindi naman siya siguro leakage. Leakage siya kung sasabihin ko yung values, 'di ba? At saka kung paano niyo iso-solve. Kasi may mga different types of solutions akong gagawin eh. All right? So you are going to
Kailangan ba calculator?
Yeah. Kasi magko-compute sila ng absolute count eh. Okay? Paano ba sila nag-exam, sir? Naka on cam?
Kita yung screen,
okay.
Kita yung mukha nila, kita yung kamay.
Ay, patay tayo dyan. Paano kung ayokong nandaraya? Sa lahat ng ayoko nandaraya. Paano yun, sir? Paano mo malalaman? Baka mamaya may naglagay ng formula doon sa ano nila. Sa calculator nila.
Well, if I may make a suggestion, isama mo na yung formula sa question. That way, tabla na silang lahat.
Okay. Yeah, that's better, right? That's better. Or mas maganda open notes for formula na lang. Hindi. Baka mamaya may mandaraya dyan i-open notes. Oo. Wag na lang pala. Alright. Oo, ako din actually kapag gumagawa ako ng exam for my interns, wala din talaga akong tiwala sa kanila. I always have the assumption that they're cheating. I'm that paranoid. And that's one of the reasons why I think I'm single up till now. Paranoid tayo. Oo, paranoid. Sad. Christ in Chichi and Kazuha. Anyway, a reticulocyte is an RBC that has lost its nucleus but has retained aggregates of RNA within its ribosomes. Okay? So what does a reticulocyte look like? Did I put a quick picture here? Oh, no, I didn't put a picture. I remember I put a picture there. All right, so let me cancel out this presentation first. I want you guys to see the appearance of a reticulocyte. Group hug is Adrian, why you like that? All right, so let me cancel out this one because I'm going to share another picture for you guys. Reticulocytes. Hang on a sec while I look for the retics in my computer. Okay. Is it still sharing? Hang on a sec. Where did I put the picture of reticulocytes? Because some students still don't know what reticulocytes look like. All right. I think this one is yeah, this one. Can you guys see it in the group? Please tell me if you see it.
No po, sir.
Wala pa. All right, hang on a sec. Hindi na-download ko pa naman yun para sa inyo eh. Kasi pinakita ko to dati sa intern ko. Hindi niya alam kung saan ang retics, kung ano-anong tinuturo niya. So baka mamaya you might fall into the same trap. Okay? So this one.
Speaking of retics, no, magkaiba po ang reticulocyte sa nucleated RBC, ha?
Oo, yeah. Yeah, actually yun. Ayan. Alright, so this is what a reticulocyte looks like. Alright? So it looks like it looks like it's peppered with bluish spots. So, sir, pag nag-count ako, sir, same ba sila ng ika-count ko? Yes. Same lang sila. Basta anything where there's a lot of bluish, this bluish peppers, I would call it peppered. Like, you know, when you buy a donut, there's like nuts on it. So those are the things that you need to put on. All right? Those are the things that you need to count. Okay? So they're basically remnants of RNA. They're not, it's colored blue. It's colored blue, but it's not really composed of iron as opposed to Pearl-Prussian blue. Okay? So a lot of my students get confused when I show a slide of reticulocytes and Pearl-Prussian blue. Pearl-Prussian blue stained slides, bone marrow slides. Sometimes they would confuse those two things because they're both colored blue, but this one in that case it's usually peppered. The appearance usually is peppered around the cell. All right, so it has lost its nucleus, but it has retained aggregates of RNA in the sample. Okay, so nucleated RBCs are not one of them. They may be seen on the same slide or same sample, but they are not the same, okay? So please be mindful of that one. Ask yourself the question, what is a reticulocyte? Is it polychromatophilic normocyte or normoblast? Normocyte, right? A nucleated RBC somewhere between polychromatophilic normoblast and orthochromatophilic orthochromatophilic normoblast also. Okay, yung nipple shaped, that one that I showed you yesterday. Okay, so that one is a nucleated RBC. Okay, so please don't forget the difference. All right. Now, how long does it take for retics to stay in the bone marrow after losing its nucleus? So we're going to. I think this is the proper time or the preferable time for me to discuss to you what's the physiology of reticulocytes. It stays in the body it stays in the bone marrow 3 to 4 days before going into the peripheral blood. It stays in the peripheral blood for 1 day before becoming a mature RBC. So, baka itanong mo, "Sir, why you lying?" Gaganyan na naman si Adrian kasi nagparan siya ng retics counts niya. So for example, isa sa mga practical exam nyo, gagawin ang sample na kukuhanan nyo si Adrian. Ganyan siya. Sir, why do I have reticulocytes? Because you already said that it was in the bone marrow for it stays in the bone marrow 3 to 4 days. Well, it does go into the bloodstream for 1 day. Okay, it will go to the bloodstream for 1 day, and it's normal to see reticulocytes in your in your peripheral blood, but there is a range. Of course, there's a range, right? So usually the range would be around 0.5 to 1%. Okay, for kids it's around 1 to 5%, 1 to 5%. Sorry, 1 to 5% to 2.5%. But normal values change depending on the manufacturer, based on the manufacturer of a particular automated analyzer or a machine. But that's just something that you need to take into consideration when you're doing reticulocyte counts, okay? It depends on your methodologies as well as the manufacturer of your automated analyzer. So it doesn't necessarily mean that you have to memorize these things, okay? But for potassium and blood pH, follow the ones in the books, okay? I made that realization when I was taking the exam for potassium, and for blood pH you got to remember it. Okay? Now, assess what is assessed by reticulocyte counts. Basically, or retics counts, it assesses erythropoietic activity. Why? Because the more retics you produce, or the more retics in your peripheral blood, the more likely that you are suffering from, the more likely that your body is producing blood cells. And when does the body keep on producing blood cells? When there is, of course, hemolytic crisis, all right, or which is basically anemia. Okay, but we're going to discuss anemia further. But when there is a need for blood cells, all right. So imagine, for example, si Ana Jamema. Okay, si Ana Jamema, bigla siyang nahiwa ng yung kamay niya nahiwa kunwari ng doon pa sa artery. Dadami na ba kaagad yung niya, yung retics niya? After 2 hours kinuhanan siya ni Adrian. Baka sasabihin na naman ni Adrian sa akin, "Sir, why you lying? I thought it was increased. I thought when there's increased erythropoietic activity, you're going to see a lot of reticulocytes." No, it's not like that. It will take time, of course. Why? The body needs to go through the process of erythropoiesis. How does erythropoietic activity begin? Hypoxia. She needs to suffer from hypoxia, of course. And when there's hypoxia, the kidneys can detect slight changes in oxygen activity, right? Changes in oxygen activity controls the release, the feedback mechanism of erythropoietin. All right? So when there's increased erythropoietin activity, there will also be an increase in erythropoietic activity. Okay? So, kung lagpas 1 day nang nagbi-bleed out si constantly, pero hindi pa naman in such a way na inabot na ng 1 ang hemoglobin ni Ana Jamema nung nahiwa siya sa sliding door, for example, ng Capital Medical sliding door, no? Hindi ko alam kung may sliding door na, baka mamaya na social na sa Capital Medical Colleges eh. Tagal na ako hindi nanggaling doon, si Kuya Bells lang naalala ko. So, for example, nahiwa siya sa sliding door, hindi pa siya, after 2 minutes, after 2 hours, hindi pa. Siguro after a day, doon pa lang natin makikita yung increase ng erythropoietic activity. Kaya natin siya ipaparetics. Okay? For acute blood loss, I don't think you're going to see a change in a patient's unless it's massive blood loss. All right? So it detects erythropoietic activity. So usually it has something to do with the erythropoietin of the patients. Okay? Now, what are the stains that we use? Again, paulit-ulit. Anli, bakit kailangan kong paulit-ulit na sinasabi sa inyo na kailangan ninyong gumawa ng supravital staining? And why do you need to keep on doing supravital staining? That's because you need to do what? Reticulocyte counts. And there are several there are several stains that you use. Most commonly, we're going to use new methylene blue, which is approved or which is recommended by the NCLSS or NCLS pala, sorry, or National Clinical Laboratory Standards. Okay? And methylene blue. All right? Brilliant crescent blue. So they might ask you in the exams which of the following stains is recommended as a supravital stain. Sometimes they wouldn't ask you what test. Sometimes they would ask you as a supravital stain. That's why I use these two words interchangeably. Retic count, what else? Supravital staining, just for you guys to be reminded of these of the difference or the similarities. Okay, I can use them interchangeably, especially for hematology. Okay, now principle of Retic's count. It's a bit wordy, so you guys can just read it out. I'll just read it out for you guys. The cells are stained supravitally, and the Retic's count is conducted. When you use the term supravital, the staining procedure is done when the cells are still alive. Okay? And fixation with alcohol is not part of the procedure. Why? Because when you fixate a sample in alcohol, it will kill the cell off. It will kill off the cell. Okay? And we need the cell to be alive. Why? Because there's RNA remnants. Okay? Or ribosomal remnants. Okay? Now, the retics are RBCs with 2 or more blue-stained granulofilament material and a non-nucleated RBC. See the difference? Okay? See the difference? Both of them appear in cases where there is increased erythropoietic activity. But only one of them is considered to have granulofilamentous material, and that is retics. Okay? If it's a nucleated RBC, it is different. Okay? Be mindful of that one. I've reminded you several times na. Pag inulit-ulit pa natin yan, para na ako sirang plaka, sir. Okay? So the recommended sample for reticulocytes are EDTA samples, of course. So in hematology, the only time you're going to use a different colored tube is when you're doing coagulation testing and ESR. Okay, black top kay ESR, blue top kay, or light blue top rather, kay coagulation. Right? EDTA for most of the tests. Now, what is the formula per percent reticulocyte count? Remember, percent reticulocyte count lang muna ang pinag-uusapan, ha? Percent reticulocyte count. You're going to count the reticulocyte counts. You're going to count the retics. Divide it by 1,000 RBCs observed. Multiply it by 100. For example, you counted 50 retics per 1,000 RBC. Multiply it by 100. Now, sir, ang hirap. How do I practically do it in the laboratory? Diyan makakatulong ang experience ko sa inyo. Ganito guys, ang technique. I'm always assuming that in most cases, kung ang pasyente is not really polycythemic, all right? And obviously, the patient will not be polycythemic when they request for retics. But there are some cases that some doctors, they will do that. Retic count. Especially for general, exclusive VIP general checkup, as in lahat papatest. Ang assumption ko is always, estimate ko na lang siya. 100 usually per field ang laman ng isang circle sa akin. For practical to ha, practical. You don't need to count 100 RBCs. Okay? Per field.
Makinig kayo kay Sir Manuel kasi
Alright.
minsan may makanya-kanyang secret technique yung mga
medic. So I always make an assumption na every field, when I say every field, when you look at the microscope, gagantuin ko na lang. When you look at the microscope, every field So example, this one is one field, 100 100 na laman yan. For me this is my technique. Okay? 100 na laman yan. Hindi ko na kailangan bilangin lahat ng RBC niyan. Ang gagawin ko na lang, bibilangin ko na lang yung retics. Alright? So mag-move ako sa susunod na field. Bibilangin ko na lang ulit yung retics. Move ako ng ilang field. Now, kung ang assumption ko is 100 ang laman ng isang field, alright? Kung 100 ang laman ng isang field, ilang fields ang bibilangan ko, Joanna? How many fields will I count if I'm basing my estimations that I have 100 cells per field? How many fields will I count? The retics on. Joanna Baltar. Kasi siya yung may naghahaha eh. How many fields do I need to count? Baka pag-practicalin kayo ni Sir Marco eh.
Nagdagdag ng question sa exam, bigla may mga picture.
Oo, no? If my assumption, ulitin ko, Joanna, if my assumptions that in every field, there's always 100 RBCs, and I only need to count the retics present in every field, how many fields do I need to count?
10 po.
Very good. O, di ba? Very good. Alright? Ngayon, minsan kapag sinisipag ako, binibilang ko siya isa-isa. Pero, isang field lang yung bibilangin ko. Bakit? Bakit ganon, sir? Kasi, yung first field na binibilangan ko, doon ako magbe-base ng assumption ko. Na, okay, somewhere around 80 yung cells. Alright, so I need to count probably around 8.5 or probably 11.5 fields, something like that. I don't need to include half of the field. Parang ganon. Practically speaking, that's easier, and that's easier, and if you're working in a very toxic environment where there's a lot of samples being submitted, you cannot count 1,000 or 100 cells per field. Okay? It's impossible unless na lang yung mata mo parang laser or automated analyzer. Okay? Alright? Clear? Clear ba tayo, guys? Baka mamaya kasi bigla kayong bigyan ni Sir Marco ng 10 slides ng retics. Tapos
magbibilang ng RBC, no?
Oo.
Hindi ko rin gawain yan.
Hindi ako nagbibilang ng RBC counts talaga. Kasi bakit?
Refer muna sa machine, tapos tsaka magbibilang.
Dun sa sa pinanggalingan ko sa MC, wala kaming machine. 'Di ba? Manual lahat. Tapos meron pang may cases na, for example, nasabugan ng paputok yung 2 bata. Oh. Tapos massive bleeding. Ibig sabihin, bibilangin ko ng 1,000, bibilang ako ng 100 per field. Ano kayo, hilo? Ay, magbibilang ako ng 1,000 RBCs. Ano kayo, hilo? Alright, so ganon.
May discrepancy, doon lang ako magmamanual.
Oo. 'Di ba? At least alam niyo kung paano magmanual. And even today, there's still actually, if you're going to ask me, they cannot fully automate reticulocyte counts. Why? Because even up till now, as many accredited hospitals that I've been working on, internationally accredited hospitals that I've been working on, they still cannot provide an external quality control or a third-party quality control for reticulocyte counts. Usually, it's only for WBC, RBC, and other tests related to the clinical other routine tests. Very rarely have I seen hospitals participate in third-party external quality control programs for reticulocyte counts. Why? Because there's still a lot of subjectivity when it comes to doing reticulocyte counts. Okay? So yeah. Now, attachment that is added on the eyepiece when doing a reticulocyte count. This is what you call the Miller disc. Okay? This is a Miller disc. And the purpose of the Miller disc attachment is to provide, to reduce the effort needed to count RBCs and giving a more precise result. Why? Ano bang itsura ni Miller disc? Para siyang hemocytometer sa loob, pero attachment siya sa eyepiece. Meron siyang squares. Okay? Usually low power siya. And then, you can make, the squares have an estimate of how many squares you're going to have. In each square, there is an assumption na 100 RBCs ang nasa loob nun. So all you need to do is just count 100. You just need to count 10 also. You just need to count from 10 slides, from 10 fields. If it doesn't look like there's 100 cells, just move on to the next slide. Just move on to the next field. That's the purpose, and that's the reason why it's much more precise, because it gives the reader an easier chance just to read the samples or just to read the slides. Okay? Now, how many large squares are counted in the Miller disc? Ito na tayo niyan. Computation na naman. You need to count in 9 large squares. So it's composed of, I think, the standard Miller disc has like 18 squares. Or sorry, 18 squares. But all you need to count on is 9 squares. Okay? All you need to count on is you count your retics on 8 squares, and you count your double RBCs on 1 square. Mali pala ang sabi ko. Sorry. So 18 squares siya. You use 9. Just make an assumption na kunyari 9 yan, marami. You count on 8 squares. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Alright, so bawasan natin tong isa. Dito kasama kunwari. So yan, 9. Basta 18 siya sa standard. All you need to do is to count on 8 squares, the retics, and on the last square, you count your WBCs. You count your RBCs. Okay? Now, how do we compute? Formula using the Miller disc. You count the number of retics counted on all 8 squares, multiply it to 100, divided by the number of RBCs counted times 9. Okay? So for example, in the question, you counted 25 on the Miller on 8 squares of the Miller disc, multiply it to 100, and then you counted 109 RBCs in one large square, then multiply it by 9. That will be your reticulocyte count. Compute for me whilst I drink water. I'll check your answers in the chat box. Ulitin ko yung question. Gusto ko mag-compute kayo. You counted 35. And then the number of RBCs you counted was 118. Compute 4% retics using the Miller disc. Okay? What is percent R? Okay? I'll give you guys some time. Where is my again? By the way, guys, this question actually appears in ASCP exams. Okay? If you have prospects to work abroad, I suggest you study this one. Okay? So I'll give you 5 minutes to answer this question. Okay? I'll share it in the window for you guys. Ano ko ba Ayan. Ano ko siya? Baka maharangan yung formula. Ayan, dito na lang. Okay? So I'll give you guys a couple of minutes to answer the question. and then type it on the chat box. Okay? Okay ba, guys? All right. So mini break for me, not a big break for you guys. Okay. So what was our answers, guys? All right. So what was the answer to the question? Can I see your answers? Let's start with Charisse. What's your answer, Charisse? Oh,
Sir, 3.295 po. Yun kanina.
okay. Very good. So, dali no? Madali lang siya, no? Right? Okay, so ganun. 3.92 or I could have accepted 3.3 because in clinical terms, they don't really care about more than 2 decimal points. They would just go with just 1 decimal point. Okay? But anyway, thank you so much. That is how you compute for your retics. Now, we have arc also. Sorry. Medyo madilim. My gosh. Ayan. Alright, so arc. What is arc? Absolute reticulocyte count. Okay? Absolute reticulocyte count and clinical value of absolute reticulocyte count. What is it useful for? That's the question. It's used for patients who have undergone marrow transplants. Okay? It's useful for patients who are who've undergone marrow transplant. Why do we need to have an absolute count? Because we need to know if their bone marrow transplant is actually working. Okay, we want to see the hematopoietic activity in these patients. All right, now what is the formula? It's easy. All you need to do is divide your reticulocyte counts to your RBC count in this unit. Okay, it's a very easy, straightforward question. All right. Next, we have another one, CRC. Ang dami naman, sir. Yes. Yan yung bulk ng questions when it comes to retics. So, sometimes you might be seeing these questions over and over again. There's several names for this computation. All right? Corrected. By the way, this is corrected reticulocyte count. And the other names for this calculation is your reticulocyte index or your reticulocyte hematocrit. Okay? Reticulocyte index or your reticulocyte hematocrit. Okay, so how do we compute for this one? Or what is the principle rather for this one? Percent reticulocyte may appear to be increased because of a lot of factors like early release from bone marrow or decreased number of mature red cells. This computation corrects for the degree of anemia in a patient compared to the normal hematocrit of 0.45 ml. Liter per liter, sorry. Or percent. Okay? You can have percent. I just wrote here liter per liter. Alright? So, it computes for the degree of anemia. Okay? Now, let's assume that you already understood the importance of ARC and CRC. Now we need you guys to compute for the percent reticulocyte index or the reticulocyte count, or you need to compute for corrected reticulocyte count. You need this formula: percent reticulocyte count divided by patient hematocrit divided by 45. Percent reticulocytes counted patient multiplied by patient hematocrit divided by 45. Okay? Why is it 45? Because based on the principle, it is a computation that corrects for the degree of anemia in a patient as compared to the normal population's hematocrit, which is at an average of 45. Okay? Clear? Now, most analyzers would release hematocrit result as percentage. How would you convert it to LL per units or liter per liter units? All you need to do is divide the hematocrit result by 100. Okay? And you're going to get the result, and you're going to get liter per liter units. So in your exams, you might be asked to convert this one first, or convert your hematocrit results to liter per liter units. Now, I'm going to give only the formula for CRC, ARC, and percent reticulocyte count. I will not give you the computation how to how to convert your hematocrit percent results to liter per liter. Okay? So yun na, parang meron na din akong parang may leakage na pero parang hindi. Grabe naman to, sir. Grabe ka naman, sir. Hindi mo na binigay sa amin lahat. Now, we have a practice question. Okay? So, your patient has 45% retics and the hematocrit percent of the hematocrit level of the patient is at 37%. Your job today is to compute for the patient's CRC. Okay? I'll give you again 5 minutes whilst I eat another orange. Okay? Uh-huh. Okay, do you guys see it? Do you guys see the clock on the side? Do you guys see the clock on the side? I'm sorry.
No.
No po, sir.
Okay. Sorry naman. So, yung buong screen yung i-share ko. Entire screen. Earning. So, this one. Ayan. Okay na. Shared na, guys. Ayan. So, ito na. Timer starts now. Please compute for the patient's CRC. Again, I'll give you guys 5 minutes. This is basically the amount of time you need to spend on a question on your exam with this kind of questions. You need to just spend like probably 5 minutes. If it takes you more, just skip it. Okay? That's my advice to you guys. If you think you're going to take a long time to answer that particular question, just guess. Okay? That's the average time you're going to spend on that particular question. That's why I'm giving you guys 5 minutes and 30 seconds. Okay? So again, I'm going to give you guys some time to solve for this. Alright. Okay. So, let's see. Ano sabi ni Charisse? Sir, feel ko masyadong mataas na kuha kong sagot. Tingnan natin. Alright. Sinagutan ko na siya the night before. So, let's see. This is your solution. Okay? You need to convert first the hematocrit to liter per liter. So divide it by 1,000, divided by 100. You're going to come up with 0.37. Okay? Everything else will be pretty much straightforward. Okay? 4.5% multiplied by 37 multiplied by open close parenthesis 0.35 divided by 0.45, you're going to get the result of 3.7%. Yes. So, Charisse, congratulations. You are, I would consider you the mathematician of our class for today because you're the only one who submitted your answer. A big round of applause for Charisse, guys. She put an effort in answering the questions. Thank you so much, Charisse. Now, another one that you need to consider is RPI. Sir, ano ba yan? Ang dami naman. Ano ba yan? This one is the reticulocyte production index. So it's different from reticulocyte index. It's reticulocyte production index. And this is based on the principle of shift correction during erythropoietic stress, where nucleated RBCs are released from 3 to 4 days in the bone marrow to as little as 1 day. So what do you mean? But what do I mean by this one? There is stress, of course, right? So there's stress. Instead of the reticulocytes or the nucleated RBCs, which will result to which evidently will become a reticulocyte of staying in the they usually stay at as I mentioned before, they usually stay at the bone marrow at 3 to 4 days. They would only stay within a day before being released. So medyo ito yung measurement kung saan namamadali ba yung mga RBCs na lumabas kaagad sa bone marrow. That's the principle of the test, reticulocyte production index. Now, the cells released early in the marrow are known as shift cells, and they usually have a polychromatophilic appearance. Okay? They have a polychromatophilic appearance. What is the maturation time for retics with respect to the bone marrow? I'll give you a table. If your retics, if you have a hematocrit level of 4 to 4, this is actually an important don't forget to review this one because this is an important chart. Maturation time usually is 1 day for hematocrit levels for the hematocrit levels at this stage, okay? And for 35 to 39, it's 1.5. And as it decreases, so does the maturation time increases. So both of them are basically inversely proportional. Okay? So clear? Not very what do you call this? Not very common. It's not very commonly asked in the board exam. Usually, if they're going to ask in the board exam, they're going to ask you about the principle, and the principle is going to go something like this. It's going to be paraphrased in a different question. So the principle of RPI is blank blank blank. Then you might have a paraphrased version of this one. So it measures the number of shift cells, okay, or it measures the number of polychromatophilic nucleated RBCs, or it measures the production index of reticulocytes that would normally stay in the bone marrow for 3 to 4 days, but they are forced to go out of the bone marrow within the day. Something like that. Okay? So usually they will ask that kind of question. Alright? Now, how is RPI calculated then? Wow, medyo mahirap to. Kasi you need to compute for a lot of things. Okay? You need to compute for a lot of things, guys. You need to compute for CRC. Okay? You need to look at the patient hematocrit for liter per liter. You need to compute for the patient hematocrit, and you need to compute for the maturation time for RBCs in the peripheral blood relative to the patient's hematocrit. So where do I get that one? You need to go back to this table. Okay? So I'll give you guys a practice question similar to this one, and you're going to answer it later on at the end of our lecture. Don't worry. Last topic. We're going to take. This is going to take a couple of minutes. Don't worry about it. Fetal hemoglobin determination. So HbF. We're looking for HbF this time. So we've finished with reticulocytes. Now we're going to talk about fetal hemoglobin. Okay? So I asked yesterday what is the clinical significance of measuring fetal hemoglobin or determining the number of fetal HbF positive cells. And what is again the importance of HbF or detecting HbF in the blood or body fluids? Can anybody still remember? What about Adrian? Kasi hindi na nagre-raise ng hand si Adrian today pag nagtanong ako ng question. Okay, tahimik din si Adrian. What is the importance muna before we answer this slide? Let's go back to the previous slide. Give me an importance of the measurement of the relevance rather of fetal hemoglobin determination. What is the relevance of fetal hemoglobin determination in the clinical setting? Anybody? Anybody? No? Come on. What about Joanna Baltar?
Ano po, parang yung distribution po ng oxygen from the mother to the child.
Okay.
Ganun.
She's partly correct. We want to measure fetal hemoglobin present in the mother because we want to identify if there might be a case of HDFN, or we want to identify if there is fetal maternal contamination of blood of the mother's of blood from the baby to the mother, so that clinicians can administer ROGAM. Okay? What's ROGAM? Anti-RH antibodies that can be delivered intravenously to the mother so that she will not be sensitized to RH, to produce RH antibodies. Bakit? What is the importance ba of producing? What is the relevance of RH antibodies ba? When in the first pregnancy, baby is okay. Baby is RH positive, mother is RH negative. The problem is when the baby contaminates the mother's blood with fetal blood. This in turn will sensitize the mother to produce anti-RH antibodies. Now, the next time Mama Bear gets pregnant, okay? The next time Mama Bear gets pregnant, Mama Bear serum or plasma will kill baby number 2, resulting to what we call hemolytic disease of fetus and newborn. Okay? So clear? We're clear on that one? All right? So that's one of the reasons why we do fetal hemoglobin determination. That's not the only one, but that is the most clinically significant important reason for doing it. Okay? Yes, tama, Joanna. Parang ina-attack po si Bebe. Yes, hindi baby talaga, no, si Bebe. Kalerky talaga ang mga students, ang mga terminologies ng mga baby, Bebe. So I have to also be lit pagka nagle-lecture pala sa inyo. Kailangan kasi yung mga terminologies, Bebe, di ba? So for example, si Joanna, RH negative. Kunwari lang, theoretically, Joanna is RH negative. Kung nagkaroon siya ng jusawa na RH positive, there's a tendency that that the baby that Joanna and her bebe, um, the offspring of Joanna's bebe and her bebe, baby na nga lang. For example, yung jowa ni Joanna na lang, they procreate and they make a and they had an RH positive bebe for the first time. She is going to have a problem. We need to determine her RH antigen, RH antibody in her serum. And one way to do that is through these tests. Yes, through these tests. We have two tests. Kleihauer-Betke, okay, and app test. Okay? Kleihauer-Betke and app test. Let's talk about fetal maternal hemorrhaging first. Fetal maternal hemorrhaging is tested using KB test, or this is the test that is commonly used to determine fetal maternal hemorrhaging, Kleihauer-Betke or the KB test. Okay, please don't forget Kleihauer-Betke test. Now, what is the principle of the tests? Well, Kleihauer-Betke, blood films are in Kleihauer-Betke. Blood films are made using mother's blood that is fixed in an acid bath. So instead of using methyl blue, you're going to use an acid bath. Now, the mother's blood will appear as ghost cells, while fetus, meaning the blood with HbF, will stain pink. Okay? So that's basically the principle of Kleihauer-Betke. You make a smear, fix it in an acid bath, and then examine the following. Okay? Usually, you're going to count the fetal blood sample. Okay? Now, what is the other name for Kleihauer-Betke test? This is also known as acid elution test. So maybe in the exams you're going to be asked the question, what is the purpose of doing acid elution test on an RH negative mother, so you don't get confused. Okay? So sometimes they may refer to it as acid elution test, but obviously this is Kleihauer-Betke. Now, the reagents that we use is going to be you're going to need four reagents, sorry. Ethanol, which is 95% ethanol, which is your fixative. The acid bath is going to be your citrate phosphate buffer. The acidic stain that you're going to use is Ehrlich stain. This will stain HbF. Okay? Counter stain, or for the background and your ghost cell, will be erythrocin. Okay? Will be erythrocin. So please remember the importance of this following of these reagents. Okay? Now, normal values. Usually in a normal pregnancy where fetal maternal hemorrhaging is not expected, you're going to see 0.1%. But for full-term newborns, it's going to be 9%, greater than 90% for newborns. Okay? If there's fetal maternal hemorrhaging, it's around 1% and above. And you need to compute for ROGAM. Okay? So I guess that is the end of our lecture for today. Let me double check. Do we have any more? We have more slides pala. Sorry. What is the other term for app test? This is also known as alkaline denaturization test. Okay? This is a test to use to differentiate maternal and fetal blood from newborn's stool. Okay? Why? Why do we need to know this? Because you need to know if the baby's stool has maternal blood. Why? If you look at it differentiates maternal blood and fetal blood in newborn stool or vomit. Why? In some cases there is vaginal bleeding, and maybe if for example you tested fetal blood in vaginal blood from a pregnant mother, then the baby would probably be stillborn. Okay? We want to avoid that. We want to avoid cases where we want to detect first if there is cases of a stillborn baby. Why? Because if the baby vomits or poops out stool, poops out stool with HBF, there's a big chance that the baby is going to be a stillborn baby. Okay? Now, what does a positive app test going to result to? A positive app test means that there is fetal blood present. A negative app test means there's mother's blood present. So usually this is done on bedside. It's done bedside. But why do we need to do this? Why do we need to know about this? This is because some laboratories, they have POCT, point of care testing. Okay? So there's some labs that have point of care testing, satellite labs near patients who require app test. And they need to have QC and QA, or quality assurance and quality control. Okay? So we need to know this because we need to know if the results that they're giving out to their patient is actually positive, is actually true positives or true negatives. Now, what is the principle of app test? Basically, blood is fixed in water, and you release the hemoglobin from the either the stool or vom or from the vaginal blood that you get. The sample is centrifuged, okay, and the supernatant is mixed in alkaline solution. Adult hemoglobin will turn yellow or brown, while fetal hemoglobin will remain pink. Okay? So all you need to remember, adult hemoglobin will be denatured by the alkaline solution. Kaya siya nag-turn ng brown. Now, because of the alkaline nature of fetal blood, the sample will remain pink, even with the addition of an alkaline solution. Alright? Now, what reagent is used in the supernatant fluid of app test? Why do we need to use the supernatant fluid? Why do we need to double check the supernatant fluid? Maybe because the sample has been lysed, or there is lysis, so we can confirm it using 1% sodium hydroxide. Okay? So we can confirm that negative result or the positive result using sodium hydroxide. Why would the supernatant turn yellow after the addition of an alkaline reagent? Adult hemoglobin may be present, and HbA is less stable and is oftentimes converted to hematine. Okay? So that's the reason why we need to confirm it using 1% NaOH. Alright? Clear? Cool beans? That is the end of our lecture for laboratory tests. I'm going to give you guys how many? An hour and 30? Would you guys want an hour and 30? What time is it there in the Philippines na ba?
11:44 po.
11:44. So we have a lot of time. I think we can probably go and discuss anemia today if we still have time. But if we don't have time, don't worry. I still have 2 more days with you guys. I think. I'm not sure. I'll confirm with Sir Marco later. But anyway, I'll see you guys after an hour and 30 minutes. Okay? All right. Yeah, sir.
Di ba hindi ka may lakad ka on that Friday or Thursday ba 'yon?
Friday. Yun yung flight ko papalik sa Philippines. Ikaw talaga.
Yeah.
You forgot na.
Ayun
Yung
nga.
lakad. Yeah. So, ano yun? Susunduin ba? Ano ba ang price mo pag susunduin nila? Wala na, no? Tapos na yung walang